Good afternoon. Thank you for joining us for today's Lung Life webinar, Let's Talk COPD, How to Be Part of the Conversation and Decision Making with Dr. Bhagaloo. My name is Jill Hubick, and I'm a registered nurse and certified respiratory educator with Lung Saskatchewan. It is my pleasure to welcome you and to be your host and moderator today with the hopes of helping you to live your best lung life. Before we begin the presentation, I would like to acknowledge that the land we are hosting this webinar on is on Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux, as well as the territory of the Métis. Lung Saskatchewan affirms our commitment to reconciliation and the Truth and Reconciliation Commission of Canada's calls to action. We acknowledge the many First Nations, Métis, and Inuit whose footsteps have marked these lands for generations. And we are very grateful we are able to host this event where we are. Following Dr. Bhagaloo's presentation, we will have time for a moderated question and answer period. So if you have questions for Dr. Bhagaloo, we want to hear from you. Please type your questions into the question feature on the webinar software, and you'll find this feature on the top right-hand side of your screen. If you want to watch this webinar again, or if you want to view any previous Lung Life webinar presentations, you can do so by visiting our website, lungsask.ca. This education webinar series was created to empower those living with and caring for those with lung disease to live better. Thank you to AstraZeneca for sponsoring this webinar and for your contributions to lung health. AstraZeneca and Lung Saskatchewan are both rooted in utilizing science to transform healthcare and education. We appreciate your partnership very much. All right, it is now my pleasure to introduce our presenter. Dr. Bhagaloo completed his undergraduate training in South Africa and relocated to Canada in 2008. He pursued additional training with RESPTREC through Lung Saskatchewan in 2013, and then he completed his CRE and CTE in 2014. Most recently, he completed his Master's of Science in Respiratory Medicine with distinction. He currently serves as a co-lead in the Department of Family Medicine in Regina and is the Provincial Occupational Health and Safety Senior Clinical Advisor within the Saskatchewan Health Authority. Respiratory medicine has always been his passion, largely inspired by his personal experiences with asthma. Welcome, Dr. Bhagaloo.
Good afternoon and welcome, everybody. My name is Nishen Bhagaloo, and I'm a family physician here in Regina. I'd like to thank you all for spending part of your day with us. My hope today is that we demystify COPD, spotlight symptoms that often hide in plain sight, and show you how shared decision-making keeps patients, families, and clinicians on the same page. So whether you live with COPD, care for somebody who knows or has COPD, or guide patients in primary practice, my hope is that this hour will focus on you and hopefully designed for you. So some quick housekeeping. Before we deep dive, we are scheduled here for 1 hour. The chat box is open the entire time, and our moderator will surface things for questions and answers. And this will be recorded. And at the end, there'll be a copy of the COPD action plan or a link that will be available for you to be able to download it and share it with your clinician. So these are the 5 objectives that form the backbone of tonight's conversation. And my hope is that by the end, you should feel confident answering what COPD is, why small symptoms matter, how to craft a goal-oriented care plan, and which questions will keep the dialogue productive. Every slide that follows from here on in will tie directly back to at least one of these aims. So what exactly is COPD? Well, COPD isn't one single disease, but 2 pathological twins, as I like to refer to them, made up of chronic bronchitis and emphysema. Well, what is bronchitis? Bronchitis essentially is a narrowing of the air tubes with swelling and mucus. Emphysema are the pops of many leaves so that they flop instead of springing back. And what happens is these tiny air sacs can't recoil, so they essentially end up collapsing. And what does that lead to eventually? Well, it's almost like breathing through a straw clogged with glue. As many of you can imagine, that would be extremely uncomfortable. Importantly, the progression of COPD can be slowed dramatically once we take away the irritants and we start evidence-based therapies. So how do healthy lungs work? What are we dealing with here? Well, imagine your lungs as an upside down tree. The trunk is your windpipe. It splits into branches, so essentially these big air tubes, and then into twigs, smaller tubes, and then finally into millions of tiny leaves. And these leaves are called air sacs, and these air sacs essentially are referred to in the diagram as the alveoli. So how does breathing work? Well, every time you breathe in, you draw air in through your nose and mouth, down the windpipe, through the branches and twigs, until it reaches the leaves, essentially the alveoli. Each leaf is surrounded by tiny blood vessels, so each alveolus for all intents and purposes. And then the oxygen slips in through these very thin walls of the leaf into your blood, while carbon dioxide moves from your blood and moves exactly in the opposite direction out into the air sac, and essentially you breathe it out. So think of this like a rubber band. The walls of those air sacs will have those elastic fibers, and when you take a deep breath in, those bands will stretch. When you breathe out, they snap right back, pushing the air out very easily. Some of the things that keep the airway clean, you have mucus and you have little hairs, and we refer to those hairs in the airway as cilia. So what do? They trap sticky mucus, they trap dust, and they trap germs. And what they do is they form this sweeping action. So imagine taking a broom and sweeping dirt out. You go front and back, and that's essentially what happens in the airway until it works that junk all the way up to the top so you can essentially cough it out. Now, your heart will then pump blood through those tiny vessels around each sac, and your lungs will make sure that the amount of air reaching each tiny little spot lines up with the amount of blood so that oxygen and carbon dioxide can swap places as efficiently as possible. How does your brain affect this? Well, the brain is always checking the levels of oxygen and carbon dioxide in the blood. So if carbon dioxide goes up and oxygen goes down, it tells you to breathe faster and more deeply. No real thinking needed at this point. So why in COPD is the entire thing made more difficult? Well, in COPD, these rubber band fibers wear out. They don't really snap back well into place. So stale air essentially gets trapped in the leaves, in those little air pockets. The tubes get swollen and clogged, and the cleanup systems don't work as well. So every single breath that you take entails more effort. So things essentially become progressively more difficult. So let's deep dive a little bit further into what goes wrong specifically in COPD. As I mentioned just now, the tiny airways are flexible like drinking straws. In COPD, they swell and they get stiff. So there's less room for the air to flow in and out of. As I said earlier, the junk builds up in the airway and becomes very sticky. So if the tubes get clogged, it's even more difficult to move air in and subsequently out. What happens as well is that those leaves or those air sacs lose their shape. When they lose their shape, the amount at which it controls oxygen and carbon dioxide to swap places becomes affected. Why? Because the surface area gets smaller. So imagine a leaf losing its size and getting smaller and smaller. When that happens, you're having a mismatch of oxygen and carbon dioxide. When that happens, the amount of oxygen in your blood drops and the amount of carbon dioxide increases. So what does that mean? You're dealing with an imbalance which would make you feel short of breath and can lead to what we call flare-ups. So when we talk about treatments, and we're going to discuss this a bit later, what do the treatments do? Well, they open up the pipes. You take puffers, open up those pipes. They try to make them less stiff so air can move in and out. They also quell the swelling. So some of those medications have anti-inflammatory effects. They prevent or decrease irritation, and they decrease the amount of the mucus or junk. So they try to keep the airway a little bit more springy. They try and prevent you from getting infection, which can predispose to a lot of these symptoms. And all in all, try to keep you healthy. So what are some of the risk factors that you can and cannot change? Well, let's look at the things that you can change. Tobacco smoking is essentially responsible for 80 to 90% of cases. It is the biggest culprit, and every single cigarette you smoke affects your lung capacity. So as we're going to talk about later, quitting is still the single biggest step to slow down damage. Secondhand smoking is also a big problem. Even if you don't smoke yourself, breathing in somebody else's smoke still adds up. Vaping is a problem. There is this misconception rather that vaping is slightly safer than smoking. Truth be told, vaping isn't regulated, which means we don't know what's present in every vape. And the studies are still ongoing, but we know it's still very problematic. Household pollution is also a very big problem. If you look in countries where we're still cooking on open fires and we're using wood and coal and dung for heat, that unto itself poses a big problem. When you look at workplace and occupational irritants, so when you think of dust, chemical fumes, vapors, all of those will slowly wear the airway down. And then traffic pollution. Traffic pollution, I believe, is a problem in all parts of the world. And when you're looking at those tiny particles that come from cars and from trucks, you can't always seal your windows. Not every vehicle is set up to deal with that. And so that in itself becomes a big problem. What are some of the things that you cannot change? Well, cannot change your genetics. There is a condition called alpha-1 antitrypsin deficiency. And in a nutshell, it leaves the lungs more vulnerable. Even if somebody has never smoked, if they have this particular problem, they are at risk for developing COPD. Age, when we're young, we have a lot of spring in our airway. We have a lot of flexibility in our airway. As we get older, and you can't beat the clock, the characteristics of those airways change. When you think of past exposures, so if you have lived in an environment where occupational exposures were a problem, if you've lived in an environment with significant outdoor pollution, or you've worked in an environment with a lot of pollution, that eventually could catch up with you. So those are some of the things, unfortunately, you cannot change. So what are the classic COPD symptoms? COPD, I want to be clear, can present in many different ways, but these are some of the easy things that one can look at. We think of exertional dyspnea. So going for a walk, going up a flight of stairs, going for a light jog, initially may have been easy. But as COPD progresses, sometimes these activities of daily living can be impacted. A chronic cough and shortness of breath are probably the two most biggest symptoms that could easily indicate the possibility of COPD. A cough, sometimes a cough that could be clear, white, or even sometimes a dry cough. Wheezing, typically people will report wheezing through the night, or if they picked up an infection, they tend to report maybe wheezing a lot longer into the infection, and they're finding that it's difficult to recover from colds or infections that they sometimes dismiss as something that's viral and don't realize it actually could be something more sinister. And then fatigue. A lot of people that live with COPD will complain of ongoing fatigue. And a lot of the times, they may adjust their lifestyle to typically help alleviate that fatigue. So what are some of the symptoms that people and clinicians may miss? Well, we'll start with morning headaches. Morning headaches are sometimes a hint that rising carbon dioxide levels overnight are a problem. Remember, COPD often whispers before it shouts. Losing weight without trying, sometimes ankle swelling if it involves other organs, a change in mood, so either anxiety or a low mood, accompanied by fatigue as well, and sometimes some difficulty in breathing, harder than maybe you anticipated that it should have been. So some patients will report that they're unable to keep up in their day and they feel a lot more out of breath than what they used to, and come the end of the day, very tired. They'll also report a struggle in their sleep patterns. So sometimes COPD may accompany a condition called sleep apnea, where you stop breathing for a period while you're sleeping, and that could result in further deprivation of oxygen to the brain. So if a patient comes in and they're talking about a very disrupted sleep and they're complaining about fatigue, some shortness of breath, that really should be resonating in your mind that, hey, we could be potentially dealing with undiagnosed COPD. And then your mental health. Your mental health struggles significantly. Sometimes you're unable to explain why you're feeling down or feeling anxious or pulling away from social activities because breathing feels harder, and you will compensate. So maybe you were playing pickleball or used to going out for a run, and now all of a sudden you're not doing those things because you don't want to be feeling tired and short of breath. So it's very important that you spot these quiet symptoms early and talk to a healthcare practitioner and try and get in front of this and get the appropriate treatment. So why early detection? Well, early detection saves lungs. Save your lung, save your life. I always say catch it before it sneaks up on you. A spirometry machine or a spirometry test or a full lung function test is a very, very quick office test. It could take as long as 20 minutes, usually typically an hour, because there's a lot of counseling that goes into it. There's a lot of history taking and a demonstration of how to use some of the inhalers that they'll give you. Quitting smoking. I tend to use many opportune moments, rather say, to counsel a patient on quitting smoking. And even if it takes as short as 30 seconds, at least put the idea in the head. And I know a lot of patients who continue to smoke sometimes may become slightly frustrated, but I try to use every opportunity to revisit it. And sometimes even for as short as 10 seconds, just to say, you know, you can still do it. You know, it's important. And if a patient's adamant they're not going to quit, hopefully try and have the conversation about cutting down. So that's very important. So the gold standard for detecting spirometry is, the gold standard for detecting COPD is still a spirometry in the office or a full pulmonary function test with your specialist. So patients with COPD and productive cough have an increased risk for exacerbations and death. Well, what do we mean by exacerbations? So anybody with COPD that's struggled with, sometimes we call it an exacerbation, a flare-up, an infection. And what essentially happens is over a period of 48 hours, the amount of which they're coughing starts to increase. So the mucus typically becomes thicker. It could be yellow, it could be green, it could be brown, it could be blood-stained. Their shortness of breath tends to worsen. They may or may not run a fever, and they're finding that their rescue inhaler is not working as well. We refer to that as an exacerbation. There are many things that can cause an exacerbation. Changes in the environment, viral infections, bacterial infections, congestive heart failure, are some of the few that can cause these flare-ups. And what we have in front of us here is a study by Lindbergh, which showed the relationship between a productive cough, these exacerbations, and a mortality among patients with COPD. And the study showed that productive cough was common and increased the risk of these flare-ups in both males and females, both in those with and without COPD. But the COPD patients with a productive cough had the highest risk for these flare-ups and had a significantly higher risk for death, even after adjustment of common risk factors. So things like their age, gender, BMI, smoking habits, and associated risk factors like heart disease. So very, very important to appreciate those symptoms, especially in somebody who hasn't been diagnosed. So what does the diagnostic workup look like? How do we get in front? What are we going to be doing? Well, the symptom story. I typically tend to ask, how long have you had a history of cough or shortness of breath? Does it get worse? Is it getting better? What makes it worse? What makes it better? Typically go over the smoking history. Very important. How long have you smoked for? How much do you smoke a day? And I will typically tend to follow that up by asking about a history of vaping. A lot of the time you ask somebody if they smoke and they say no, you would assume that encompasses vaping. Don't make that mistake. Very important to follow it up with, do you vape as well? Then we typically tend to go over occupational exposures. Do you work in an environment with dust, with chemicals, with cooking fuels? Do you have a family history of COPD? Is there a current history of secondhand smoking exposure? And importantly, did you grow up in a household with either mom and dad smoking? Very, very important to revisit that. The physical exam will typically involve listening to lung sounds, other clues like things like wheezing. Typically patients, depending on which stage of COPD they're in, may have a barrel-shaped chest. If they're struggling, they may be using their neck muscles to breathe, again, dependent on how advanced the disease is. As I mentioned earlier, a spirometry test, very simple, very easy to use, very easy to do. And a skilled technician will take you through it. And this test is able to tell us in large part whether you do or don't have underlying COPD. Sometimes your physician may order a chest x-ray, and if you've been smoking for an extended period of time, and they are concerned about the possibility of underlying lung diseases, the possibility of diseases like bronchiectasis or even lung cancer, they may choose to order a CT scan of your chest, just in case you were wondering. And of course, if you are diagnosed with COPD, it is very important that everybody have this blood test done. It is recommended that an alpha-1 antitrypsin blood test, simple blood test, be conducted and done at least once in anybody that is officially diagnosed with COPD. So when you put the entire thing together, when you've discussed your history, you've had an examination, you've had these breathing tests done, you had the necessary blood work, you may have had relevant imaging. You put the entire thing together and you come up with confidently diagnosing COPD and ruling out a host of other conditions. And what this essentially does is that it will chart the best treatment plan for you going forward. So this slide, for some of you, I know I do have patients that will request a copy of their spirometry, and I'll be honest and tell you that it's not an easy test to interpret. I've been looking at spirometries now for over 15 years, and it does take a lot of practice, and there's quite a bit of training that goes into it. According to the GOLD criteria, COPD is, and this is just on spirometry alone, is divided into 4 stages. You have the mild, the moderate, the severe, and the very severe category. And there is something called an FEV1 on the test, which calculates how fast you can breathe out in 1 second. And it takes this, puts it into a ratio, and then these ratios correspond with the different stages there as referenced by GOLD. Now, I've put the typical symptoms in, but I want to be clear that this is absolutely not a hard and fast rule. This is very much just a guide. I've seen patients with very severe COPD being diagnosed, sitting in my office looking very comfortable, and there's no hint of it. And I've seen patients diagnosed with mild COPD, and they typically will be pretty breathless and not feeling too good. So again, those typical symptoms are very much just a guide. An important point here is that every time you have a flare-up, as I mentioned, whether it's infective or other causes, it tends to impact your lung function more frequently. So this is something that's very important to keep in mind. There is no set consensus on how often one should have a spirometry. And I think a lot of it goes in large part is judged clinically and how controlled you feel the person is in front of you if you're a clinician. So I will typically go maybe every 2 to 3 years, especially if somebody's stable, maybe even every 3 to 4. And for somebody who's not so stable, who's susceptible to having these frequent flare-ups, I may typically tend to go do that a little bit more frequently. So what are the 5 universal treatment goals? Well, I think every prescription, vaccine, or rehabilitation referral should tie back to at least one of these 5 North Stars, right? Breathing more easily. If we're able to reduce daily breathlessness so that you can talk, walk, and play with less effort, then we're giving you back your quality of life. If we can prevent flare-ups and cutting down on the sudden or bad days that take you to a practitioner's office or to the emergency room in hospital, we keep your airways calm and we can keep your airway clear. If we can protect your lungs by slowing down the damage through smoking cessation, through optimizing your inhaler therapy, through rehabilitation, by keeping your vaccinations up to date, we can keep you going for a lot longer. If we can improve your muscle strength and endurance, and this is a very big part of the rehabilitation, or home exercises, YouTube. I tell patients who can't afford to leave the home or cannot afford treatment programs or don't have access to it or live in more remote sites, YouTube has all the information that's necessary. Saskatchewan Lung Association has all the information that's necessary. So we can connect to a lot of this pulmonary rehabilitation virtually. And obviously, if you're maintaining your weight, if you're sleeping well, and very importantly, we're managing your mood so that you can enjoy life and avoid a lot of these complications. Now, this is a very busy slide, but in 2023, the Canadian Thoracic Society revised some of its guidelines here. Basically, what it said in a nutshell, and I won't go into too much detail here. Like I said, it's a very busy slide, but it basically said that all symptomatic individuals with COPD should be on therapy. So historically, we may have just used an inhaler like Ventolin just to say when you're feeling short of breath, when you're feeling uncomfortable, maybe you're a little bit more fatigued at the end of the day, go ahead and take it. But outside of that, there's nothing much else that we should or we need to do. That entire messaging has changed. So we call them dual therapies, and it's referred to as a LABA-LAMA therapy. So therapies that are typically found in single inhalers. And what they essentially do is they open up the airway from the outside by relaxing it and from the inside by pushing it open. And as we talked about much earlier, if you have an airway that's nice and open and it's a lot more flexible, it's much easier for that airway to get rid of the mucus, subsequently get rid of the junk, and prevent these exacerbations that can be very problematic. For patients that are a little bit further along in their journey, so diagnosed in the more moderate and severe category, who may tend to find themselves using frequent courses of antibiotics and steroids, they're more highly predisposed to these exacerbations or these flare-ups. They tend to visit the emergency room or their physician offices a little bit more frequently. We have the triple therapy. So that is the LABA-LAMA, as I just explained, and then we add the steroid into it, which works with its inflammatory properties. And what's really important about the update on the guideline here is that once you start at the baseline and you move through different inhalers and you get to triple therapy, you do not go the other way. So we don't take you down. We graduate you up, and once you're on that triple therapy, you are maintained all the way going forward. So optimization. But what are the goals? So we've been talking about it throughout the presentation. Number one, alleviate dyspnea. If you're not short of breath, you're much more comfortable, you're enjoying your life more, and promotes good mental health. It improves overall health. Critically, prevent exacerbation. So prevent these flare-ups. You prevent these flare-ups, you preserve your lung function, and you will end up reducing mortality, right? You reduce mortality, reduce hospitalization, making sure that you have a better quality of life as you're going forward. So this is a very busy slide. There are many classes of inhalers out there. There are combination therapies, there are individual therapies, and I won't really spend any time on this, but this is available for reference. And again, depending on where you are in your journey, your healthcare practitioner will decide on what the appropriate inhaler is. It was interesting. I was listening to a very keynote speaker about all the different therapies out there, and we were making mention of the fact, or he was making mention of the fact that for all the excellent treatments out there and all the excellent modern molecules and their ability to improve your lung function, if you don't take it properly, it simply doesn't matter. So if I have time myself in the office, I will and I have access to the inhaler that the patient is using, I will try to go over it with them. If I don't, it's my request of either the pharmacist or a respiratory therapist or a certified respiratory educator or anybody really, an allied healthcare professional that's involved in the patient's care to spend that time with them. So very importantly, if you're using a metered dose inhaler or a puffer for all intents and purposes, these are some of the steps that one would take to go ahead and use their inhaler. And I'll go right to the last part there where it talks about a spacer device. If your physician is giving you a puffer and the drugs that you're taking come in a puffer, it is very, very important that you take it with a spacer. No matter how good you are, the use of a spacer device, so it's essentially a device where the puffer goes into one side and the mouthpiece goes in on the other side, and it gives you time to, once you're using an inhaler to get the molecule into your lungs. You really don't have to be an expert. And again, no matter how good you are with using your inhaler without the spacer is always recommended. Now, that being said, there are other inhalers and other devices rather that are not MDI based. We call them DPI, so dry powdered inhalers that don't necessarily need the use of a spacer. It is also very important to appreciate that by after 6 months, especially if you're a brand new COPD patient, by after 6 months, your technique has dropped around 60%. After 9 months to 1 year, it's dropped about 30%. So revisiting your technique, spending time trying to perfect the technique, maximal inhalation, holding your breath, making sure that whatever device it is, you breathe out nice and slow, and you're always rinsing your mouth and spitting out. It doesn't matter if you're using a spacer with or without an MDI, or you're using a powder, always remember to rinse and spit out. Very, very important. I get asked the question a lot about pulmonary rehabilitation because we know the access to pulmonary rehabilitation isn't always readily available. Now, the graphic here on the right, that illustrates how inactivity can lead to deconditioning, mainly caused by breathlessness. And this breathlessness in turn can increase the patient's fear of exertion to a point that they'll start to avoid both physical and social activities. So in essence, you're dealing with this vicious circle where a patient will feel even more isolated and depressed and essentially result in a decreased quality of life. So the text box on the left shows that pulmonary rehabilitation is well proven, it's structured, and in a multidisciplinary setting, it can encompass a patient assessment, physical training, so the peripheral muscles, and again, as we mentioned earlier, even if it's lightweight training, it's still very important to maintain your muscle mass. It may or may not, depending on where you're receiving your program, involve occupational therapy. Education is a cornerstone. Smoking cessation, any opportunity to discuss smoking cessation. Nutritional intervention, so making sure that your calories are maintained. I find a lot of the time people who struggle with COPD are calorie deficient. If you don't have the fuel to power your body, that on its own will lead to this level of fatigue and restlessness through the day. So that's a very, very important point that needs to be highlighted. And obviously, psychosocial support is very, very important. Taking care of their mental health, very, very important. Smoking cessation. I have a lot of people that say, hey, I've been smoking for 30 years, 40 years. I've now got COPD. I have all these puffers. Is there any real value in quitting smoking? And what you see on your right is what we call the famous Fletcher-Peter curve, which shows that FEV1, as I mentioned earlier, and it is a key lung function measure, and it shows it over time. And what it shows is that anybody that continues to smoke will have a further decline in their lung function. But even if you quit, even in your middle ages, after smoking for an extended period of time, the slope of the decline snaps back to match a never smoker. So it's never going to be that of a non-smoker, but it does start to move in the right direction. So nothing slows lung function. Nothing slows the decline of lung function than ditching cigarettes. Within 5 years of quitting, the FEV1 slope may mirror that of somebody who's never smoked in their life. And there are different forms and combinations of smoking cessation. There's Champix on its own. There's combination therapy with drugs like bupropion and nicotine replacement therapy. These therapies can be used as long as 6 months. And one of the things I like about Champix is it's a therapy that's designed for smoking cessation. And there is some flexibility in the dosage. I know some people don't tolerate taking Champix twice a day. So I recommend go ahead and take it once a day, especially if bad dreams are a problem, and maybe combine it with some nicotine spray or nicotine lozenges. That is a possibility. And I never try to rush or try to bring about an abrupt cessation of smoking. Because remember, you can be on the Champix for as long as 6 months. And if somebody's smoking 10 cigarettes a day, one of the ways to approach it, especially if they've been smoking for a long time, one of the things I do is say, how about cutting down by 1 cigarette a week? So start the Champix. You can be on Champix while you're smoking, and maybe in week 1, smoke your 10 cigarettes a day. In week 2, try 9 cigarettes a day, and so on, all the way up to the 10 or 12 weeks. The goal has got to be ultimately smoking cessation. Don't focus too much on the speed at which they quit, rather the end game. Keep in mind, relapse is a part of the journey. And the average smoker will need 5 to 7 attempts. So when somebody comes back to you, even if they say, listen, I've been smoke free for a long time, use any opportunity to revisit, even if it's a couple of seconds. Ask the question, have you quit smoking? Have you relapsed? Did you have a small relapse? And sometimes you find that stresses, acute stresses in people's lives can sometimes bring about this relapse. So use that as any opportunity that you can to continue to ask the question when it comes to relapse. Oxygen therapy. Long-term oxygen therapy isn't cosmetic. It does extend life, especially if somebody truly has hypoxemia. Depending on where you are, and these are some of the criteria up there, depending on where you are in your journey, we typically would target around 15 hours a day for somebody that requires it continuously. And there are many oxygen devices that you've now got the handheld, you've got the portable packs that can slip around your shoulder and your back so that you can still continue to travel. So you will typically find for those more severe and very severe patients that may or may not have comorbidities with things like heart failure, oxygen therapy plays a very critical role. I put the slide in here just because, especially for those severe and those very severe patients, surgical options are there. Now it's a very limited clientele, and it is decided by your specialist whether or not you are a candidate for lung surgery. But in essence, what it does is it takes those bits of lungs that have been destroyed and that basically have caused areas of collapse, and they remove them and they allow the healthier sections in your chest cavity to expand and work a little bit better. That is in a nutshell those patients that may be considered. Obviously, it's a little bit more complicated than that. Now we go back to spotting a flare-up early. These flare-ups, these exacerbations that I've made reference to so many times during this talk today. Remember, they don't just make you feel worse for those 5 or 6 days. They shave off lung function over time. The sooner you can spot a flare-up, the sooner you can catch one, the less permanent damage you're going to suffer. So what are some of the early warning signs? Number 1, you may find yourself using your rescue inhaler a little bit more frequently. So maybe 2 to 3 times a day. You may think it's a change in season. You may think it's just a cold that you're picking up. Pay very careful attention to it. I would advise you track it, write it down, document how many sprays you've used. And if you start to find that it's a sudden deviation from what you typically do, it could be a signal that maybe it's time to act early. Watch the color of your cough. So here is what we call an action plan. And the green zone is essentially the all clear zone. So it's normal breathing, you take your usual medication, you keep up with your daily inhalers, and you continue your healthy routine. In the yellow zone, we call it caution zone. Now, this action plan may look a little bit different. They are different from province to province and location to location. This is just a crux of what an action plan will look like. The yellow zone, on the caution zone, you may have an extra cough, your chest may be slightly tighter, you may end up using your rescue inhaler a little bit more. And then you would typically then to step up your bronchodilator or your short-acting bronchodilator and maybe consider use of a short burst of steroids, typically about 5 days. So starting steroids typically within that 24 hours of the yellow zone will cut your chance of ending up in a hospital or maybe even in a physician office by up to 1/3. And then we get to the red zone or the danger zone. And that's typically a patient that will be struggling with severe breathlessness. They may be slightly confused from the lack of oxygen. They're unable to speak in full sentences. They get short of breath with very minimal physical activity. And typically the advice here is to get to an emergency room as soon as possible because whatever it is you have may be progressing. And typically at this point, the patient may need admission. Now, anybody can help you fill out this action plan. Anybody from a respiratory educator to a respiratory therapist to a nurse to your physician to anybody that's involved in your journey. And once you're very well or comfortable rather with how to use it, this could definitely be a lifesaver. We all know that access to care, especially same-day access to care, is not very easy unless you're going to an emergency room. And I find these action plans extremely valuable. What's really important as well to guide a patient is that when you have to execute this action plan, you should still be seeking that medical care, especially if you're between yellow and red. And I'll tend to tell patients, if you're going to be in the yellow, you're going to go ahead and take your antibiotic-based steroid, call your physician's office, make an appointment. Even if it's going to work, you still need to be followed up. You need to make sure that the infection is gone. You need to make sure that it is infection and not potential of cardiac issues that could be causing you shortness of breath. So it's still very important. Start your action plan, follow up with your healthcare practitioner. Now, what are some of the very, very subtle signs of deterioration? Let's take a look at, let's start at the top. What do you notice? Well, the walk test distance drops, or like many people who use a smartwatch to monitor the number of steps that they take in a day as a form of monitoring their activity, you may find that your step count is reduced quite significantly. Basic chores in your household may start to be impacted. Breathlessness during simple tasks, shopping, brushing your hair, brushing your teeth, cooking. And why does it matter? Well, if you are winded by your normal routines that used to be effortless, that's a red flag that something more is going on in your chest. Whether or not it's infection, whether or not it's the inappropriate or incorrect therapy, whether or not step-up therapy may be required, it's very important. When you think about this morning headache that we've spoken about before, and typically a headache that makes it very difficult to focus by the late morning, why is that important? Well, carbon dioxide overnight can leave somebody very foggy, give you this pounding headache. And it's a sign that maybe your lungs aren't clearing out carbon dioxide as well. It could also herald underlying sleep apnea. So it's important to talk to your healthcare professional if this is happening. When you're thinking about excessive daytime sleepiness, so dozing off during the day, brief micronaps, maybe while you're watching TV or you're reading, why does that matter? Because interrupted sleep or low overnight oxygen tends to make you drowsy and erodes at your quality of life. When you think about unplanned weight loss, so typically about 5% of your weight unintentionally over a 6-month period without trying. So somebody that may weigh over 150 pounds and has lost over 7 pounds. Well, why is that important? Because your body burns extra calories just to breathe. So losing weight could signal your muscles, including the breathing muscles, that there's less fuel. Less fuel means less strength. So that's very important. And then obviously monitoring the visits either to the emergency room, your practitioner's office, or even the urgent care centers. And repeated visits basically essentially mean that these flare-ups are not under control, and it is definitely time to reassess whether it's your inhalers, your rehabilitation, a new action plan, new treatments. These are a lot of things that one then has to be cognizant of. So as I mentioned earlier, these flare-ups, these exacerbations are associated with increased risk of hospitalization and death. And in this study here, they said that 1 in 5 patients died within 1 year of their first hospitalization following a COPD exacerbation. And even moderate exacerbations, those flare-ups that don't require hospitalizations, increase the risk of mortality greatly. So about half of COPD mortality events were respiratory in nature, or by the lungs, and about a quarter were related to the heart, showing that the effects of the exacerbation are not on the lungs only. They do affect the heart as well. And it is possible that if an exacerbation risk is reduced, whether it's the proper management, that the mortality risk associated with these exacerbations would decrease significantly. So this graph follows on with what I just said, that these exacerbations are associated with what we call a cardiopulmonary risk. They do affect the heart as well. And then the risk of these cardiac complications following even a moderate exacerbation basically means that the risk of having a heart attack is doubled in the first 5 days after post-exacerbation. Think about that for a second. You go in, you get admitted, you think it's all about your lungs, without realizing that the risk of a heart attack is very significant in that 5-day period. There's also a 40% increase of stroke within 10 days after having an exacerbation. And keep in mind as well that there are some physical complications affecting the joints, affecting the muscle, and ultimately affecting your quality of life. So it's very, very important to appreciate that it is not just the lungs that are affected. Now, we've talked about this earlier, that the mental health and emotional health matters. Why? Let's revisit this mind-body connection in COPD. Your brain and your lungs are in a constant conversation with one another, and worrying about being out of breath makes your neck and chest muscles tighten, which then actually makes breathing a lot more difficult, and in turn, the extra struggle actually fuels anxiety. So you got to try and break this breathlessness anxiety loop, and it's just as important as taking your inhalers and maybe even oxygen therapy. So anxiety triggers your fear. It may trigger the use of accessory muscles, as I just mentioned, making it slightly harder to breathe. So what are some of the things that you can do to try and slow this uphill battle? Well, behavioral therapy, speaking to a therapist, your counselor, your psychologist, that'll teach you how to manage these scary thoughts. Replace them with calmer ones. So changing the narrative from, I'll never be able to catch my breath again to, I've handled this before, I'm going to try and get a grip on things. Pulmonary rehabilitation, as we spoke about earlier, combining that exercise coaching, those breathing techniques, educational settings, exercise sessions in a group setting, patients watching other patients, dealing with the same problems, encouraging one another, knowing that you're not the only one out there struggling with this particular problem. And caregiver burnout. This is a very, very big problem, I think, that we face. We don't pay a lot of attention to the effect that this has on the caregivers, the families, the spouses, the siblings, the kids out there. That up to 40 to 50% of COPD patients that have anxiety, depression, we find that this affects their partners equally, but a lot of the time they're suffering in silence. So when caregivers burn out, patients could ultimately end up in the ER slightly more frequently. So it's also really important that it is explained to patients that the importance of pulmonary rehabilitation, taking inhalers every day, using and executing that action plan as soon as possible ensures that you stay healthy. If you're healthy, your loved ones stay healthy, both physically and mentally. You got to remember, this is a team effort, and there's just no way you're able to fight COPD alone. So you've got to be drafting some meaningful goals. You've got to define what matters to you. Motivation is different for everybody. Some patients want to continue that quality of life as they get older for their children, for their grandchildren. They want to keep themselves busy by working part-time, spending more time in the garden, playing golf part-time. It's important that it is explained to a patient to set those goals and the SMART goals outlined here. And goals don't have to be very big. Goals could start as small as walking 600 meters a day. I had a lady with moderate COPD about a year back. That's pretty much all she could tolerate, about half a kilometer every day. And she gradually built up to it. We managed to optimize her therapy, and she went into pulmonary rehabilitation program. And now she's doing between 4 to 5 kilometers a day. It's quite remarkable to see that. So start small, start slow, log your goals, track your progress. There are many different ways to do that. There's your cell phones that can do that on their own. They have these Smartwatches, you could do it the old-fashioned way by writing it down on a pen and paper. And it's important to take this to your healthcare provider. The Canadian Thoracic Society talks about managing symptom burden. So it's not just about the flare-ups, but how do you feel? Equally important, are you getting better? Are you making progress? So if you've got your healthcare provider who has all of this available and has a glance at it, at least we know we're moving in the right direction. And remember that every plan is tailored to your conditions. So you sometimes have people saying, my friend was told he has moderate COPD. He can do a lot more than I can. Well, does he have other comorbidities? Do you have other comorbidities that he doesn't? Does he have more time than you do in the day? Is he on different therapies? How you understand moderate and maybe what is actual moderate is slightly different. So it is different for everybody. So as I said earlier, COPD is a very, very big team effort. You've got your general practitioner, you've got your chest specialist, your respirologist, the lung doctor. And I tend to think of the general practitioner, your family doctor, as the quarterback, ordering the tests, sometimes making the diagnosis, prescribing the medications on a daily basis, and keeping an eye on your overall health. So essentially your coach. Think of your respirologist as the one that's fine-tuning the orchestra. So it's just making those smaller changes and maybe looking at things like your CT scans of the chest and managing tricky flare-ups, especially if you're spending a lot more time in hospital. A sleep specialist, we mentioned earlier that sleep apnea is a big problem with COPD. So sleep specialists could help address some of that overnight drop in your oxygen. If relevant, a cardiologist, especially if it's affecting your heart. When you look at your pulmonary rehabilitation team, you've got your physiotherapist, your OT, your respiratory therapist. They're coaching you through your breathing techniques. They're designing you these exercise plans and coaching you through these 6-minute walk tests. You've got your dietitian as part of that team to making sure that your caloric intake is adequate. You may or may not have a psychologist on board as well. And then obviously your pharmacist. Your pharmacist plays a critical role a lot of the times when access to care is limited. Clients will go to their pharmacist and look for that care as well. So it's important to know how and when to reach your team. If you know your physician office is really busy, get that action plan in place. If you don't have access to them, try to access your pharmacist or your respiratory therapist or anybody in your rehab team. Have these fail safes in place. Know how to contact them. Know who's available on short notice. And importantly, know where your nearest emergency room or urgent care center is as well. And when you look at your action plan, make sure that you're paying attention to how to navigate it, because it's all good and well on the first visit, but make sure you're revising it regularly. And also make sure that if you have a store of your antibiotic and your steroid at home and you haven't had to use it for a long time, remember these drugs do expire. So making sure that you stay up to date. So what are some of the high impact questions? And we got 2 pages here that you as a patient should be asking their physician. First question I get asked, can you explain my latest spirometry numbers in plain language? Well, why does it matter? Well, when you're looking at a spirometry and you've got all these percentages and ratios, sometimes they feel like alphabet soup. It's just a bunch of numbers and you're not really sure what you're looking at. And I feel sometimes say as a healthcare professional, it's very simple to reference one number. Reference the FEV1. Just use the FEV1, explain to a patient based on that number which category of COPD that they're in and what it may or may not mean for their everyday life. So try to keep it very simple. And then ask them, what would be better or worse number if you look at, and what steps can be taken to move in the right direction. For each person, that's going to be a little bit different. When you look at which inhaler device best suits my hand strength and breathing pattern test, I get asked this question a lot. Which drug do you prefer? And it's a very loaded question. You could have the best therapy out there. If you can't take it, it does not matter. If you're struggling with a technique, it does not matter. So it is important as a healthcare provider to pay attention to the person in front of you. When you've made a choice, if you have a sample, get them to show you how to use it in front of you. If that doesn't work, change it. Talk to the pharmacy. Ask them to try something different. For as good as the new molecules out there, if you cannot get it into your lungs effectively, it will not work. It will leave the patient short of breath, and it really doesn't help anybody. Also very important, try to revisit the technique of the inhaler use at opportune visits. As healthcare providers, you're not going to get the time all the time, but try to schedule these appointments in such a way that maybe an extra 2 or 3 minutes, and encourage your patients to bring. So as a patient, I would advise you, bring your inhaler, take your inhaler to go see your healthcare practitioner. Keep it on your lap. It's going to trigger to say, hey, would you mind going ahead and showing me how to use it? Especially if samples or demonstrators are not available. Vaccination, vaccination, vaccination. The flu and the COVID boosters are all available by public health. The Prevnar 20 vaccination, now recommended by NACI, which covers against the 20 common strains of bacterial pneumonia, available through public health. And then there's the RSV vaccine. So up to recently, we didn't really have any treatment options for RSV. For those of you that don't know, RSV, it's the respiratory syncytial virus it is responsible for flare-ups and COPD. And now we have 2 options. Neither of them are covered, but talk to your healthcare professional and your pharmacist about the cost. The current data suggests they're as good for about 3 years, and that's definitely something you should have done. And then the other vaccinations, there are travel vaccinations on top of this. There are the shingles vaccinations, especially for those patients above the age of 50. So in a nutshell, any opportunity to vaccinate and prevent against these infectious diseases, please take it. Another question we ask is, how does one define the success or failure of a medication? Well, that's dependent on your goal. And as we said previously, using SMART goals is very important. So if you're looking to define success, it depends on the goal that you have set for yourself. As an example, if you say we're going to be looking for a 20% drop in your rescue inhaler and an extra 100 meters every 4 weeks on your 6-minute walk test over a 3-month period, that's an example of a goal. As a patient, only you can set that goal for yourself. I don't really think anybody can set it for you. People can help you guide that, but it's ultimately up to you to decide that. Do I meet the criteria for pulmonary rehabilitation referral? In my opinion, everybody should be sent to pulmonary rehabilitation, irrespective of the stage of COPD that you are in. What does my written flare-up plan say I should do first? So as we've said, pay attention to your exacerbation plan. Familiarize yourself with it. Make sure that you have medication available, and make sure that that medication is up to date and it has not expired. Spend an opportunity with your healthcare provider to move between the yellow and red zones just for clarity. Even if you're an expert on it, it only takes a couple of minutes to review it. The need for home oxygen. Well, that's something that your practitioner can set you up to get tested. There are organizations within the health authority and privately that do this testing, especially if your symptoms are worsening and triple therapy isn't quite cutting it. And that would give you a very good idea very quickly of whether or not you're a candidate for oxygen. And of course, trials, because there are new trials and there are new devices coming out, and that's definitely a conversation to have with your healthcare practitioner. So asking some of these targeted questions, make sure that every time you leave an appointment, you may have a slightly clearer next step. You're not going to be able to accomplish all this in one appointment. But whether after an appointment you're starting rehabilitation, you're tweaking your action plan, you're checking on the need for oxygen, or exploring new therapies, it just keeps your care moving in a forward direction. So a little bit at every opportunity. So what are some of the tried and tested resources and supports? Well, we have GOLD. We have the Saskatchewan Lung Association. We have the Canadian Thoracic Society. We have the Canadian Network for Respiratory Care. And these are all Canada's leading professional organizations for respiratory health. There are national bodies governed with physicians and therapists and respiratory educators. And they really are experts in this field that are going to be able to help you focus and really narrow in on what you're going to need when it comes to your goals and your treatment plan. So my advice is if you access them and they are available, make the best use of them. They're wonderful people. We're coming to the end here. When we talk about living well with COPD, These are some of the things that I briefly summarized. And COPD changes how you live, not whether you live fully. So strategic pacing will turn houseworks into intervals rather than marathon. Remember, this isn't a marathon. This isn't a sprint. This is very much a marathon. Uh, Connect to the right people. Make sure that those people are able to identify with you and try and improve every step of your journey in COPD. So as I come to an end here, remember that COPD is very prevalent. It's one of the leading causes for admission to hospital. But with the right team, a vigilant team, a team of all stars, COPD does not need to steal your independence. The sooner you act on small changes, the more long life you preserve. The more long life you preserve, the better your quality of life. Keep the dialogue open, keep moving forward, never hesitate to reach out to your healthcare team. I want to thank you all. I'm grateful for your attention. I know it's just over an hour, and if there are any questions, I'd be more than happy to take them.
Thank you so much, Dr. Bagloo. That was just fantastic. My goodness, you covered so much great information. And I also want to thank you. I know you're on vacation right now, but you've taken the time to join us. Thank you so much. And I love how you talked about how COPD doesn't um, determine whether you live fully and a good quality of life. So thank you so much for that. A reminder to everyone, if you have questions for Dr. Bagaloo, we do have a few minutes, and if you haven't already done so, go ahead and put your questions in the question feature of the software. And as well, a reminder that this presentation was recorded, and we will send it out to all of you as well. All right, Dr. Bagaloo, do you have your audio on there? There we go. Okay, nice to see you again. So some of the questions that we have are related to triggers in relation to COPD. So right now in Saskatchewan, we have a lot of wildfires burning in our north, affecting air quality throughout the province. And many people are wondering if the wildfire smoke can worsen their COPD symptoms or cause a COPD flare up.
Jill, thank you. Yes, I'm actually in Kelowna right now, surprisingly, 33 degrees, hot,
Oh,
um, beautiful weather. And thank you for having me. And that's a great question. And I think just before I left on holiday, that was a bit of what I was seeing, patients struggling with shortness of breath. And it is critical when we're discerning between a change in symptoms due to a trigger, and like you mentioned, whether it's wildfire smoke, and whether or not it's an infective trigger. And a lot of it is discerned, like I said, by symptoms. So are you just short of breath, and do you feel that when you're out of the smoke and you're in your home environment and maybe you've got an air purifier, humidifier, you're feeling much better versus that cough is now productive. It's changing to that greenish yellowish color. You're running a fever. The quantity of that cough is also increased where that mucus in the cough has become really thick. So it's important to discern between the two because it does guide which way you're going to manage that.
oh, that's wonderful. Thank you. Thank you for that. Um, because certainly we are seeing such poor air quality. I'm glad it's beautiful and warm where you are. That's wonderful to hear. You talked a lot about the importance of pulmonary rehab and exercise and the impact it can have on the whole body. There are some questions around breathing exercises. Is there any exercises that people can do at home, breathing exercises when they're feeling short of breath that you would recommend in addition to pulmonary rehab?
Absolutely. There's the basics include the tripod or pursed lip type of breathing. I don't have like that's a really good question. I wish I had a picture of that, and I think it is available on the Saskatchewan Lung Association. So a position where you put yourself into a tripod. I think of a triangle, right? And basically, what it does is it helps you control your breathing in a fashion that allows you to empty your lungs completely. You got to remember with COPD, part of the pneumonia is an obstructive lung disease. So you're able to get air in, but you struggle to get air out. So if you're struggling to get air out, you have a trapping of air, or what we call a hyperinflation, affecting the lung dynamics. When that happens, you try to get a little bit more air in. So you're squeezing more, you're struggling to get more out. So you've got this balloon that's just getting bigger and bigger and bigger. So what this type of breathing technique does is it helps you in a very controlled fashion to slowly empty your lungs. And by doing so, by being able to force the air, you reduce or decrease this dynamic hyperinflation. So you're able to get more air in that you can effectively oxygenate. So that is very, very, very important. And again, I think it is on the website. If not, you can just Google or find it on YouTube, pursed lips breathing. And it's an excellent demonstration of one method, rather, on how to improve your breathing technique.
Okay, oh, that's great. That's something that we can all do. Thank you for that. Um, there are some questions around the different medications. We know that there's many different inhaled delivery devices. There's many different types of medications, but can you explain the difference between the type of what's the difference between an inhaled corticosteroid and a steroid pill that you might be prescribed during a flare-up?
And that's a really good question. So let's break this down. If you're at the junction where you're having to take an inhaled steroid, so whether it's in a puffer, whether it's in a powder, the chances are it's part of triple therapy. So for all intents and purposes, you've been diagnosed in the right way, you have progressed in the right fashion, you typically don't have any underlying comorbidities, you're on triple therapy for the right reasons. Triple therapy itself, which has the steroid in it. Remember, the dual therapy, the LABA/LAMA, opens up that airway, relaxes those muscles. And when you've added the steroid in, it's typically to control in the inflammatory process or the inflammation. And you're trying to affect that on a daily basis, every single day, in micro amounts of these steroids. Keyword micro amounts, you're trying to affect the control of inflammation. So, case in point, when you talked about the wildfire earlier, and people being affected by it. If you're on triple therapy, maybe that wildfire, makes your symptoms a little bit worse. Maybe it triggers an inflammatory response where you're coughing up some clear phlegm. That daily steroid is there to quell the storm. In most cases, it's there to help control that inflammatory process. If you control the inflammatory process, you prevent scarring of the lungs and maybe even prevent that underlying infection from getting a little bit worse, especially if it's viral in nature. If it requires the use of an oral steroid, typically in most cases prednisone, it basically means that that entire inflammatory cascade has overwhelmed the airway. So you're unable to do it on your own. So now you're taking these really high doses of oral steroids. And you want to think of that, it's like calling on the army now to go in. Where your local police force has failed, the army now has to come in and really has got to get very aggressive and very quick control of this inflammation. And that's where the oral steroids come in. And sometimes, depending on where you are, the oral steroids themselves fail. And that's where you'll end up going to hospital. And if you're admitted, then they use the intravenous approach, which is a lot more effective because it gets to the source a lot quicker. So those are, I hope that answered the three differences between the IV, the oral, and the inhaled.
Oh, that's wonderful. I love that analogy. Calling in the army when the police force fails. That's beautiful. Thank you, Dr. Bagaloo. You have such a wonderful gift of using, complex information and research and finding a way to explain it that we can all understand. Thank you so much for that.
Thank you, Joe.
We all appreciate that. I know you talked about oxygen therapy in your presentation. There's some questions about if someone is on oxygen therapy and when they exert themselves and they see their oxygen levels drop and their heart rate goes up, would it be fair to say that it would be recommended to increase the amount of oxygen that they're receiving, like increase the amount of flow?
So, barring being an ultramarathon elite athlete, in all of us, when we go for a run, we push ourselves, we exercise very hard, the amount of oxygen that your body requires goes up. because you're breathing a lot faster, and then depending on your fitness levels, the oxygen levels are going to drop slightly. That is a normal response. So the answer to the question, and I could break it into two parts. If you're on oxygen therapy and you're in pulmonary rehabilitation, or you're going for your walk or your jog, whatever it is in the day, expect there to be a slight tailor or drop off in the oxygen saturation. Expect the heart rate to go up a little bit. That is a normal response. Again, depending on where you are in the disease. But if you've seen your practitioner, you've seen the RT team, you've gone to the oxygen team, they've tailored everything for you, and let's just say 6 or 8 weeks later, you find that you're doing simple chores at home, at work, nothing too strenuous, something that you would do on a daily basis, and you're finding the changes you just mentioned, where the oxygen levels are dropping off, the heart rate's going up, and there's no overt physical activity to explain it, you don't have any accompanying infection that maybe explains it, it may be time to go and have that reevaluated, reassessed to make sure whether or not the amount you're getting is right. Maybe mechanically, there's no issues in the system that's preventing the amount of oxygen getting to you through flow mechanisms. Maybe you don't have an underlying disease that affects the heart. Hopefully by that stage that's been excluded. And then the other important thing is if you are, and I mentioned this in the presentation, whether or not you could be dealing with sleep apnea, undiagnosed. That can also affect your oxygen at night. And so people wearing an O2 sats monitor, I know a lot of people have these smart watches, and they're sometimes come in and they'll bring in and say, hey, my watch was beeping at night, telling that my saturation was going down. That is also something to explore as well.
Okay. Oh, that's wonderful. Thank you for explaining that. Because I think when people, yeah, we have these monitors now that can show us so much and tell us so much, and when we see the numbers change, it sometimes if we don't understand why that might be happening, it can cause us to feel maybe that something isn't quite right. So thank you for that. Um, we have a question about someone with mild COPD. And they're wondering when someone has very mild COPD, how you determine if you should provide them LAMA therapy or LABA therapy.
I'm actually very, very glad that question came up. As I mentioned pretty early on in the presentation, it depends on the symptom burden. Since
Okay.
the review of the guideline, and I think even before that, we paid attention to the person sitting in front of us, and we didn't really allow whether or not it should be LAMA or LABA or SABA, just the use of a ventilator to guide us. Now, what have we moved away since pre and post 2023? Pre 2023, if you were diagnosed with mild COPD, if you were not really short of breath, you didn't really have any infections or exacerbations, you go about your life and your daily activities of living with no problem. We gave you a Ventolin inhaler, a SABA, and we said use it as needed and be on your way. Post 2023, Canadian Thoracic Society looked at a lot of data. Looked at a lot of information, and Canada is really robust for having all of that available, and said, hold on, we're seeing that even if you're diagnosed with mild COPD, even if you feel really good, even if you're not too symptomatic, you still have a slightly increased chance of having an exacerbation compared to somebody without COPD. So your risk of having these infections, whether it's pneumonia, bronchitis, whatever you want to call it, they're slightly higher. So if you had high blood pressure and you were on the cusp, I wouldn't say to you, well, let's take your blood pressure medication as needed and come back and see me and let's see how you're doing. We wouldn't do that. We would treat your blood pressure every day. Kind of the same with your cholesterol. So why do we do that with respiratory disease? And so we moved away from that. So if you're in the mild category, the recommendation is very simple. Try to get your physician to start you on what we call a LAMA, so long-acting muscarinic antagonist. We haven't quite got to getting people to switch to LAMAs right away. I know there's some issues with coverage, but it's not very difficult to get somebody there because ultimately you want to be able to maintain somebody with mild COPD on combination LABA therapy. Simply relax the airway from the outside, open it up from the inside, and maximize that bronchodilation. Because if you've got these nice big airways, you move oxygen in and out, move oxygen in and move carbon dioxide out effectively, you're going to feel a lot better. You're going to be less breathless. And that's ultimately the goal, right? Manage the symptom burden along with reducing the infections and exacerbations.
Well, that's wonderful. Thank you, Dr. Bhagaloo. We have so many questions, but I think we have time for one more. You talked about one of your slides having a full team. That it really takes a village to manage COPD, which I appreciate that. It really speaks to the holistic approach of the care that you value so much in your practice. So thank you. There's some questions about when you would refer someone to a lung specialist, because there's lots of patients, people living with COPD and caregivers that are being managed by their general practitioner but do not have a lung specialist. So when would you say, okay, I'm going to go ahead and refer you?
Let me take a step. I will answer that question, but let me just preface it slightly. In 2020, I think it was 2022, my memory eludes me here slightly. I was given the opportunity to present the Saskatchewan Health Authority COPD pathway at the Western Conference for Respiratory Medicine in Victoria. And some of the smartest people in Western Canada were in that room, and it was some from out east as well. And they were very, very impressed by how advanced and developed the health authority COPD pathway is in this province. I always tell patients it is one of the best I have seen in the country. And I've even talked to some of my friends out of country about what this pathway looks like, about the fact that it gives a patient access to a dietitian, a respiratory therapist, a pharmacist if need be, pulmonary rehabilitation, education, action planning, oxygen testing if necessary, sleep apnea testing if necessary. I don't know of another program that does that as comprehensively as well as this particular program does. And it is available to every single patient with COPD in the province. Every single patient with COPD in the province. And I know they do a lot of virtual work as well. So I give every single patient the option of enrolling into this program. And even for those people that are hesitant, I enroll them anyway. And I say to them, there's no harm in listening to the first meeting with this team. It's typically done in a group setting. If this is something you're not interested in, okay, but just give them the opportunity and the benefit to explain to you exactly what this program encompasses. In terms of specialist access, in Regina, that is a challenge. We have 6 specialists. I know Saskatoon has a few more. In Regina, that's a big challenge. So if I find that a patient is dealing with recurrent exacerbations, if I find that there are other complexities involved in their management, if I find that they're not responding to therapy, that's typically when I'll go ahead and say, hey, I think it's worth using a specialist. The challenge, like I said earlier, is getting in and then the wait time to see them. So I encourage every patient on this call, every practitioner on this call, every allied health professional on this call, utilize that COPD pathway. You will be pleasantly surprised if you haven't utilized it, how beneficial it is, how comprehensive it is, how robust their approach is. Unfortunately, the pathway, to my knowledge, doesn't link directly to a specialist yet. I think there is some conversation doing that, or the struggle with trying to find healthcare professionals or access rather to healthcare professionals, especially specialists, is a challenge I think that we're facing countrywide. I know it's a slightly long-winded answer, but just thought I'd give people that option as well and bring that up while I could.
No, I think it's great, Dr. Bhagaloo. You really are explaining, what's available to patients. Many patients maybe don't know about that. And I want to thank you for all the work that you've done to help make it easier for people to access care. I know that's really important to you and something that you hold really close to your heart and your lungs as well. So thank you. And that's all the time we have today for questions. But oh my goodness, Dr. Bagaloo, you're getting so many comments coming in. Many people are saying that this is so informative. This has been so helpful. They've learned so much. We've had a few people say that this is the best COPD presentation that they have ever heard. So thank you for all the time that you've put into this and the knowledge that you've shared with us. It's so special, and we're so grateful that you took the time today to join us, even when you're on vacation. I want to also thank again our sponsor, AstraZeneca. And I want to thank them for all that they do in advancing respiratory health and education and moving the pendulum forward. We appreciate you, and we always appreciate collaborating with you. I also want to let the healthcare providers know on today's webinar that you can download for free the CEU notice of today's presentation, and you can find it in the materials icon, and that's the one that looks like the little paper clip on the top right hand corner. Go ahead and click on that and you can download that as well. Dr. Bagaloo did a wonderful job explaining what the COPD action plan was and how it can be utilized and help you with your care. You can also go ahead and click on that icon and see that and download that for yourself to take to your healthcare provider if you don't already have an action plan. Okay, so thank you again, Dr. Bagaloo. And next up for Lung Saskatchewan, we hope you will tune into our podcast called Let's Talk Lungs. The upcoming episode is on June 18th, so right around the corner here. I Smell Smoke, How to Protect Yourself During Wildfire Season. So thank you so much, everyone. You can find out more at lungsask.ca. I hope you have a wonderful vacation, Dr. Bagaloo, and everyone stay well, stay safe, and breathe easy. Take care.